and I consider everybody in this room as a tomato. But you know what she said, how we can grow more tomatoes is to put a little wire structure so that those tomatoes can grow straight. So everything that we're getting in here is giving us structure so that we can hold accountable to the things that we should do after this session. Please join me in welcoming Maisha Minter-Jordan, who's an MD, MBA, but she's the Chief Medical Officer here at DEMIC. Studied at Johns Hopkins, as well as she hosts a cable television show on New England Cable News. So not only is she a personality, she's smart, she's bright, and she's a doctor, so you should listen to her.
All right. Following Dr. Karen Wingfield is a tough job. That was, I think, was fantastic, and Karen, you really set the stage for the discussion that we're going to have for the rest of the afternoon. So again, my name is Dr. Maisha Minter-Jordan, and I'm so pleased to be with you this afternoon to have a discussion with these esteemed panelists. I think there are a number of topics that have been raised, and what's most important is not only that we hear from the expertise of the panelists, but that we hear from all of you in the audience. So more than anything else, I really want to make sure that this is as interactive as possible and that you're asking questions. And if you don't ask a question, I'm going to take this mic and walk down the aisle and get questions from you. Because we won't learn as a community about how to address these things unless we have a discussion. Not a talk, not a speech, but a discussion. So with that, I'm going to ask each panelist to introduce themselves. I'd like for you to take roughly 10 minutes or so to talk about yourself and how you came to work with your particular organization. And then I really want to get to the meat of the discussion. What are your thoughts on what's been said so far this afternoon? I think everyone has discussion themes in their packets. And we're also going to look at those discussion themes as a framework to have a real in-depth conversation about healthcare inequalities in Boston. So with that, if we could have our first speaker to my right here, Ms. Kathy Colton.
Yes, thank you. So my name's Kathy Colton, and I work at Harvard Pilgrim Healthcare. I've been there 40 years, meaning that my employment goes all the way back to Harvard Community Health Plan, which was one of the predecessor organizations of Harvard Pilgrim. And when I started working there in 1971, my first job was to evaluate our contract with the Massachusetts Department of Medicaid. And we had an outreach center in Mission Hill, and I spent 2 days a week in that outreach center and got to see firsthand how just delivering health care wasn't enough. And so throughout my career, I've maintained an interest and an involvement in trying to understand where disparities exist in the care that our members receive and what we can do to try to reduce those disparities. I began this work in earnest around a decade ago with the Mass Department of Public Health, actually, where we first began to try to measure disparities at the health plan level. And since then, Harvard Pilgrim has been committed to this program, and we've been not only measuring, we've been collecting data about our members, asking them to share their race and ethnicity with us so that we can look at our data and see whether we're providing equal quality of care to all of our members. And we've initiated many programs to reduce disparities that have been identified. We now monitor over 70 different measures of quality, including measures of patients' experiences, and so whether they can communicate with their doctor effectively, and as well as measures of clinical quality. And so I'm very interested in what you're doing here today. I'm very interested in the report that came out about the state of Black Boston. A lot of the findings are very similar to some of what we've seen, but some of them, thankfully, are different. For example, when we look at our rates of colorectal cancer screening, our rates for our Black members are over 8 percentage points higher than they are for our white members. And we've been working in this area now since about 2006, trying to get those rates up. And we've really started to feel good about what we're doing because we're making a difference. And I wish everyone could feel good about the kinds of improvements that we've been able to make in small areas. There are other areas where we still have quite a ways to go. And I think that, well, most of what we've looked at has to do with healthcare and how healthcare can make a difference. We've begun over the last few years to really branch out into some of the areas that the mayor was talking about. So programs through our foundation, for example, that support healthy diets and nutrition, and funding for programs that make it easier for people in the inner cities to get access to good food, good healthy food. And we have a lot of other programs where we work with community-based organizations who do this work on the ground, and we try to support them. So I'm going to, with that, pass the microphone.
Great. Thank you.
Thank you, Kathy. My name is Gabriel Vonley, and let me just take a moment to thank Harvard Pilgrim Health Plan, to thank Demic and the Urban League for doing this. This is such a critical topic for our community. And this is a personal topic for me as a Black male that lives in the state of Massachusetts. Healthcare disparity is really something that starts before birth. Our community, when you talk about the terminology around disproportionate disparity, discrimination, it seems like we have the short end of all the dis. And the question here is, today we are gathering here, but we're going to leave this place and go to our various residents. And the question that always comes to mind is, how do we do something to institutionalize a change? I think we mentioned the Emancipation Proclamation by Abraham Lincoln. The body was free, but the mind remains enslaved. Our community, we can walk around, we can sit at the countertops that we couldn't at one point, where many generations have fought for us to sit at those tables. But our mind continued to be enslaved. And in order to address some of these disparities, we must first free the mind, because that's where the battle lies. And I say this from a personal experience. I grew up in Africa. I was born in Liberia, West Africa. And we talk about the village. I've experienced the sense of that village. This nation is a great nation. Our village consists of brown, yellow, white, red people. And until we can call the elephant in the room and say that we are first a part of one race, the human race, and we have to collectively resolve these disparities as a people, we are not going to get there. I currently work for Common Square Health Center as their Chief Operating Officer. I came from corporate America. I decided to come to Common Square Health Center, definitely not for the money. Okay? I worked in New York as a senior vice president for a company called Amalgamated Life Insurance Company. Multi-million-dollar, close to $1 billion organization. First Black man hired in that role. So when you spoke of your experience, we all have those stories. But it's what you do with those stories. We can no longer continue to play victim. I refuse to play victim because I've seen human beings in a worse situation. We are blessed in this country. I had the opportunity to visit my homeland during the civil unrest, where I spent some time in a refugee camp for a month. My family here, my American kids that were born here said, "Dad, why are you going over there? You're crazy." But that experience have made me to realize something. That we, I like to use the collective we, have to resolve these issues as a people. So when we talk about disparity, we have to look at the root cause. This great nation has a history of discrimination. Discrimination is something that is taught. I truly believe in that. If you take an infant to China up to the age of 18, guess what? That child is going to speak Chinese. Is that not true? I speak many dialects. My children cannot speak my African dialect because they were not exposed to it. So you are what you are exposed to. So how do we start to educate our people? It's going to take everyone in the community to get involved. You know, you look at the infant mortality rate of Black Boston, almost 4-to-1. Our children are dying even before they have the opportunity to live. That's why I came to Carmen. You look at how we even treat each other. Disrespectfully. You know, we're quick to cry racism, but we don't even treat each other right. And I'm talking about the Black folks. I've watched in my own health center when people come into that health center, how people greet them. It starts with that. That's a sense of disparity. That's a sense of inequality. When people walk into my health center. So now they call me this crazy bald-headed guy because I said, anyone that comes here that has a problem, I want you to come to my office and call me. And it's the matter of treating people with respect. People react the way you treat them. The Black community does not trust the white community because of the history. And we cannot say that every white person is bad because that is not true. There's bad in every community. It's who is willing to make the sacrifice to stand up and make the change. This is what this is all about. The way monies are distributed within our community brings a level of disparity. Before we get the money in the community, the decision is already made for us. So the community first has to become a community before we can impact change. We have to stand up. And when I say we, those of us that have been exposed to the healthcare system, that have some knowledge, we need to educate people to not have fear when it comes to seeking the right to pursue healthcare. You know, when you reach that age of 40 something and over, which I'm in that bracket, you know, my sons laugh at me because my primary care annual visit has become very interesting. Let's just say I have become very personal with my primary care. He knows me well. And we have this discussion and my boss like, oh my God, you go through that. I say, your time is coming. But I'm educating them to Benel's point. If you want to live, you have to go get it. You have to bend over, guys, I tell my son, and get that test. But I educate them from the perspective of it's okay because why? I want to live. I want to live long enough to see you guys grow up. So I'm educating them. So you see, the education starts at that young age. So now I prepare their mind that this is okay. You know, I'm a big mature guy, you know, and they see that. But I say, you know, I have to be humble in order to get to where we need to get to. So this issue of disparity within the delivery of healthcare is a critical one. Massachusetts is a trailblazer. Okay? We have close to 98-97% of folks insured as the result of the healthcare reform law here in the state of Massachusetts. But having insurance does not necessarily mean that ones have access to insurance. I want you to pay close attention. You can have insurance, but you don't necessarily have access to insurance. So these are some of the issues that we need to talk about when we talk about these disparities. People don't even know their rights. You know, if I, as a black man, got arrested down the street, all they need to do is run my license and they will tell if I have a warrant, if I'm a mass murderer. But if you had a heart attack right now, in most cases, They cannot even grab your medical record. Think about it. We have the technology. How are we utilizing the technology? So all of those things cause disparity. And it will be interesting because I have more perspective on certain things, and I want to challenge things. I don't like to just have discussions. I like to have actionable items. You know, kids bring report cards, and I'll stop here and pass it over. Kids bring home report cards. We require some level of immunization. Why are we not requiring some level of requirements to healthcare, primary care healthcare, that should be reported as a report card for every child? We have the system to do it. So I will stop here and turn it over to Ruth.
That is, in some regards, hard to follow, but in some regards sets up what I want to talk about and focus on as a continuum of dealing with disparities. You'll see on the agenda here that I've got an ESQ behind my name. I practiced law for a number of years in Boston in a big law firm. I was an associate and then a partner before I came to Dimmock. I grew up in Roxbury, about 2 blocks from here. I really wanted to use the skills that I developed in the practice of law. It's kind of a way of thinking. It is a good administrator, a good analyst, and a good financial person. I really can read a financial balance sheet and figure out what the stories are and where the bodies are hidden, if you will. And wanted to bring those skills to Dimmock. And did not have any healthcare background, social services background. But when I came to Dimmock, I think the thing that surprised me more than anything else was the position of the health centers in the medical community. We were not paid attention to. We were not seen as delivering quality services or services in some regards that made a real difference in people's lives. We were not consulted by the teaching hospitals or any other area of practice of medicine in the greater Boston area. We just were disregarded, which shocked me because we were dealing with the most critically ill patients, chronically ill patients, and had really developed ways to complement the services that the doctors were given to patients and help patients become educated, begin to take care of themselves on an ongoing basis, and therefore take care of their families. We were developing ways of writing grants to get support services in, clinicians, social workers, the kind of necessary social services that our patients needed to understand how to take care of themselves and stay healthy. It's a long process, it's a generational process, but we had been doing it since the beginning of health centers in the 60s. And it just really stunned me, frankly, that others weren't learning from our experiences and taking the work that we were doing into account and the importance of the work that we were doing into account in setting up medical protocols and in really figuring out how to begin to deal with disparities. I think that the changing world of healthcare and the cost of healthcare and where the money is in healthcare is forcing that change. And I see it as the way that healthcare delivery services and are paid for is forcing that change. And I think we're at a point where we can really take advantage of the changes that are coming to deal with disparities in a more systematic and more comprehensive way. And my thinking is that, yes, we need to help our patients learn, and the people in Roxbury, Dorchester, Mattapian, South Boston need to learn how to be assertive and ask the right questions, not take no for an answer, deal with bad attitudes, But I also think that there is a parallel learning that goes on with the professionals that deliver healthcare services to people of color, frankly, primarily. That we should demand that we be treated by those professionals with respect, that we not get the tone of voices, not get the looks, not get the dismissal, and in a way that helps people learn, and when I say people, I mean the professionals, learn how to respect all people that they serve, and especially people of color, perhaps, because there is, as I think the thread that we have talked about here, this is a country that is still learning how to deal with all peoples and deliver services and live with all peoples. And people of color are still seen as different at the bottom of the heap, and really can benefit from professionals, and you know, I say all professionals. I saw it when I was practicing law. I was in a position to comment to my partners, to associates that I worked with, inappropriate comment, etc. I think we've got to take that responsibility and in an absolutely appropriate professional way, call people on when they are giving that impression, purposefully or not, that you don't count. And I say that knowing that there's many different ways that happens. It can be very, very uncomfortable, but I think it can also be done in a way that brings the lesson home and begins to have people think about their actions, how they approach people, how they say what they say, expressions on faces, body language, as well as the actual words. And if we don't start doing that, and if we don't insist upon the other side of this equation, i.e. the professionals, all the way from the physician's assistant to the docs to the x-ray people, just the whole system, thinking about the impact that their behavior and their assumptions have on the patients. We, as a group of people of color, can work on ourselves and can be assertive. It's not going to happen unless we all work on this together, and that professionals take the responsibility to make sure that they're monitoring themselves, monitoring their offices, and making sure that the atmosphere is welcoming and respectful. So that is kind of my theme, and I think it really complements your theme and what you're saying, and takes it to another level. And so I could go on and on. I've got lots more to say, but I really think that's going to be my focus. So let me turn to Barbara.
Let me just... How's that? Okay. It might be because the two are together, though. It may be. So, okay, is that working? Yeah. Okay, great. I'm Barbara Ferrer. I'm the health commissioner for the city of Boston, and I'm honored to be here, and I'm honored to be with this panel. So I just want to start by thanking some of the very special people who are in this room, because when you think about tackling an issue like inequities in health, there are people in this room who are really unsung heroes, and we should acknowledge them. You know, the leadership of Darnell, of Ruth Ellen, of Dr. Minter Jordan, of Karen, our doctor over here, Dr. Karen. They have been working tirelessly for years around issues related to inequities. And I think we all should give them a huge round of applause, because they're leading the way. And I also want to acknowledge that there are allies, and I want to give a lot of credit to Mayor Menino. There are not a lot of mayors that stand up in a room filled with people of color and talk about racism. There just aren't. Not a popular issue for a white guy to talk about. But he's honest, and he knows that that's the issue we have to talk about. We cannot talk about inequities in health without talking about racism, and I'm going to try to do 3 things in 10 minutes.
One is talk a little bit about what those inequities really do look like in Boston, touch upon why we see those inequities, and then what we're doing about it and what more needs to be done. So let me just start with the inequities. So if you look at the 20 most commonly collected health outcomes in Boston, black residents, on 16 of them, fare far worse than white residents. And people have alluded to them, but I want to talk about the magnitude. So for example, on cervical cancer and breast cancer, two cancers where black women actually have highest screening rates when compared to white women in the city of Boston. The death rate is almost 3 times greater for black women. They tend to get the diseases earlier, and when they get the diseases, they tend to die of it much more frequently than white women. We can talk about prostate cancer for men, and it's about 1.5 times for black men in the city of Boston than white men. Homicide, black residents, 27 times greater chance of dying from homicide if you're a black male in the city of Boston than if you're a white male.
Any particular age, Barbara?
Well, I don't have it by age here, but we know that the group that's most affected by the homicide rates in the city of Boston are 18 to 25-year-old black men. Not exclusively. I mean, there are younger black men, as we all know. There are boys, young boys, and there are older black men as well. Asthma, 10 times the rate for hospitalizations for kids under 5 who are black when compared to white. And it starts at birth, where black babies are somewhere between 1.5 times more likely to die in the first year of life than white babies. And it finishes up at the end of life when black residents in the city of Boston live on average about 6 years less than white residents. And when I talk about when it starts at birth, a black baby in the city of Boston in 2009 was more likely to die in the first year of life than a white baby born in the city of Boston 25 years earlier. So these are real impacts on a collective, the collective good of our neighborhoods. You know, because what starts at the beginning, if it starts, as the mayor said, if it starts bad, you have deep problems. I think what happens though is most of the time when people talk, they stop right there, and then the assumptions start running about what could possibly be causing these differences. And let's be honest, the first place everybody goes is this must be about how people are behaving. It must be about something they're doing, some choices they're making. So let's look at infant mortality, babies that die in the first year of life, because we have a lot of data about that. And let's start with behavior. So there are a couple of things that we know that are really critical to the health of a fetus and an infant. And one is that during pregnancy, not smoking is pretty critical. Smoking is associated across the board with poor birth outcomes. But it turns out that black women who don't smoke at all, didn't smoke before their pregnancies and aren't smoking during their pregnancies, are still 1.5 times more likely to lose their baby during their first year of life than white women who smoke before their pregnancy and smoke the entire time they're pregnant. 1.5 times more likely. It also turns out that if you're a white woman who smokes, your chances of having a baby that dies in the first year of life is 1 in 9. If you're a black woman who smokes, the few that do smoke, if you're a black woman who smokes, your chances of losing a baby in the first year of life is 1 in 4. So not only do you see the relationship between black women who are taking good care of themselves still having worse outcomes, but in fact, when they do engage in a risky behavior, they're much more at risk than white women. What else do we know about behavior? Getting into prenatal care. It's a little questionable about how good that is, but if it stands for the marker as being connected to services, it stands for something that's important for women. Black women who get into care early when they're pregnant and stay in care the entire time that they're pregnant are somewhere between 1.5 and 2 times more likely to lose the baby in the first year of life than white women who don't get into any care when they're pregnant or come in very late. So we look at some behavior stuff and we go, well, maybe that's not it, maybe it's not about the behavior. And by the way, on drug use, black women have lower rates of drug use than white women, just to dispel that myth across the board. So then people say, well, you know, this is only about poverty, because we do know that being poor has a terrible impact on your health. But the truth is, it isn't only about poverty. If we look at white women who live in absolute poverty, they have their babies are 1.5 times more likely to survive, almost 2 times more likely to survive the first year of life than white women who live with modest or high incomes. And the same thing goes for education. Black women who have graduated from college have some of the worst health outcomes in terms of birth rates, not only compared to black women who didn't go to college, but also when you compare them to white women who didn't even graduate from high school. So your chances, if you're black and you went to college, of having a baby die in the first year of life are almost 2 times greater than white women who never even graduated from high school. So people often say, what's left? If this isn't about people's behavior, and it isn't about their income, and it isn't about their education, not that those things aren't important, but that's not what accounts for the difference. What could account for the difference? And the science is increasingly sophisticated that what probably explains the difference is an exposure to a chronic stressor like racism. So if you're a person of color, you probably do not go through one day in your life without thinking about the color of your skin.
Amen.
Not one day. But I can promise you, I mean, I'm Puerto Rican, but I am very white, and I can promise you that I can go through weeks without having to pay attention to the color of my skin. And any other white person that's in here will verify that, okay? I don't walk into a store and worry when the clerk is ignoring me, that she's ignoring me because she's racist. I don't worry about that. It's not, so the issue is that worry is the stress. That experience is the stress. And that doesn't even account for the real acts of racism that are well documented by institutions. The mayor said it. Where did foreclosures happen in the city of Boston? 85% were to people of color. I call that institutional racism. Banking practices were allowed to happen that preyed upon people of color disproportionately. That's racism. That's racism. And the stress of those experiences every single day accumulates. And it accumulates in a bad way. And studies actually show that what it does when you're exposed to that level of chronic stress is it raises certain hormone levels. And what are some of those hormones? There are things like cortisol. Well, why are black women more likely to lose their babies in the first year of life than white women? Because their babies tend to be born earlier, what we call more prematurely. They don't make it through the entire gestational period. Well, cortisol is a hormone that's associated with going into labor. So you got more cortisol floating around in your body, then you're more likely to probably go into labor earlier than women who have normal amounts of cortisol. And the real problem with chronic stress is that your hormone levels rise and they don't come back down. So, people say it's about genetics. There may be some genetic components. I don't know about that. I don't really believe that. What I do know is that the environment interacting with your genetics is what's probably creating this difference. And the environment is an environment that supports a lot of racist acts and racist systems. And we do have to work together to take those down. Racism is not the law of the land. Racism is a system that was built up by white people to oppress people of color. And it is something in our power to come together and figure out how to dismantle that system of injustice. And you can be very concrete. But people say, oh my God, I'm a public health department. What can I do? So let me switch. So what can we do? So we've done a few things. The first thing is we said this was our mission. This was our vision. As a health department, the most important work we have to do is to narrow that gap, to eliminate that gap. And we were going to hold ourselves accountable. So we have 3 overarching goals. One's around obesity, one's around chlamydia, sexually transmitted infection, and one's around low birth weight. Because low birth weight is a predictor of an infant death. And what we said for each of those goals is we put numbers attached. And we said at the end of 5 years, we have to narrow the gap by X%. A real number so that, now we're 4 years from now. So 4 years from now, people can look at the health department and say, did you do what you said you were going to do? You have a $165 million budget. If this is your priority, show us that you, in fact, are making a difference. Don't tell us it's a big problem. Not interested. Everybody who lives here knows it's a big problem. people of color in particular, they know this is a real problem. What are you going to do? Well, the first thing you have to do is make a commitment to do something about it. And then you have to look for those programs that actually are showing that they can make a difference, and take whatever resources you have. It's not about more resources, it's about taking what we've got and applying it to the problems that are most important. So you can't stand here and say, we don't have a grant for this. We don't have the money for this. This isn't our priority because we got funded for something else. You have to be very creative, but you have to hold true to the notion that the biggest problem we have are the inequities in health outcomes. And therefore, however we're going to do this, we have to realign the resources so that we're honestly tackling those problems. And you know, you got to walk the walk, or is that how you say it? Walk the walk. As well as talk the talk. So you know, for our health department, we have almost 1,200 people, but we have a goal to become an anti-racist institution, and that's really hard work. That's really, really hard work. I have 9 unions, so everything has to go through bargaining. 76% of the workforce is in a union. So you know, you can't just make change. You see a problem, you want to change it. It doesn't work that way. But you have to try to say, here are the practices internally that contribute, for example, to the lack of diversity amongst professionals of color at every level, if you want to start there. Or here are our human resource policies and practices that don't really encourage people of color to either apply for jobs or be retained in jobs. And that, you know, you have to do that in a way that doesn't end up alienating people or accusing people or having people say, I can't be part of this struggle. We're all learning about how to do this, but you have to be honest and say policies, procedures, and systems perpetuate inequities just as much as people do. And sometimes while you're waiting for people to change and grow, what you can do is tackle the policies, procedures, and systems. So for example, what are the policies we should fight on? Well, we should fight on sentencing reform. We should fight on sentencing. We should all fight on sentencing reform. It's not an issue for just like the people in the criminal justice system. It's a healthcare issue. It's a healthcare issue. We should fight for paid sick leave. How is it possible for people to take care of themselves and their families if they don't get paid when they're sick? Can't do it. Can't stay home. Can't stop transmitting flu. You know, we have data. We saw during the H1N1 epidemic. Which were the hardest hit communities? It's obvious. Those communities of color, and a lot of those communities were Latino communities where people are here perhaps without their papers, can't afford, we tell them to stay home, they can't stay home and they can't keep their kids home. And so the spread happens much more rapidly in those communities because people are constantly getting exposed. Not because people are bad people, not because they didn't care about their kids, not because they didn't want to stay home and they felt lousy, but because they can't afford to, because we're the only industrialized country that doesn't have paid sick leave. So I'm going to stop because I know I used up my time, but I sort of want to make the point, like, there are things that need to get done that can be done. It's not easy work, it's important work, and because you're here, I know you're committed, and I think, that's where you start. You start with the people who are committed. So thank you very much.